Hi, this is Dr. Kevin Windisch from Sparks Pediatric and Adolescent Medicine. Welcome to our video series for parents and for students. Today, I'm hoping to clarify for everybody some of the points of what's really one of the most complex of congenital heart diseases, and that is, if we can get this to work here, hypoplastic. Left heart syndrome. Remember, we can be reached at our office for consultation at 775-359-7111. And please remember, we can't really help you via the internet because that's just not good medical care. We're going to simplify some of the anatomy and some of the details so for those of you who are cardiac physiologists, or for that matter, those of you who are my attendings who decide you want to see what I'm up to in my old age, please forgive the simplifications. But I want to keep this such that everybody, myself included, can kind of get their mind wrapped around what's going on. Oops. So, first things first, basic cardiac anatomy. Everybody knows this is a heart, unless you're a physician. Because if you're a physician, you know that hearts don't look like that. If you're a physician, you know that hearts look like this. Whoops. Let's get a good muscular septum going here. And I'm not the world's greatest artist, so you gotta bear with me. This is the muscular septum of the ventricles. Okay, we got a right ventricle here, left ventricle here. Okay, and then we have our membranous septum of the ventricle, and then our atrial septum up here. And these are not going to be the greatest septa, but that'll do. Okay, coming here in the right ventricle, you have the tricuspid valve. Here in the left ventricle, you have the mitral valve. You then have your atria that come across. Okay, and coming into the right ventricle, you have two veins. You have your SVC, and you have your right ventricle, or your right vena, or your inferior vena cava. Okay. These carry blue blood from the body. Coming into the left ventricle, I'm going to draw. We're gonna go with the convention of veins are blue, arteries are red, even though the blood coming in here is red. This is oxygenated blood. All right, so you have 4 pulmonary veins coming back into the right or the left atrium. So this is right atrium, left atrium. Now, coming out of the ventricles, you have your arteries. So we're going to go with the convention of arteries are red. Let's make sure we get the directions right. So we have the pulmonary artery coming out here, and it comes up and then makes sort of a T. Okay, and then you have the aorta here, and it comes up. Make sure I get this right. Goes on top and then wraps behind the pulmonary artery. Alright, so this is your PA, whoops, and this is your aorta. Alright, so this is normal anatomy. Actually, let's see, can I use this? No, I'm not going to use this. Thank you. So, let's draw hypoplastic left heart. And in a hypoplastic left heart, there's not much of a left ventricle here. You still have your muscular septum, and you still have your atrial septum. And then you have your muscular ventricular wall down here. Okay, you have your tricuspid valve, and then usually a very atretic or very stenotic or atretic mitral valve. That's one of the most common kind of base defects that lead to this. You have your atria up here. Okay, now we have our SVC and our IVC. Superior vena cava, inferior vena cava. Drains the head, drains the rest of the body. We have our 4 pulmonary veins. 1, 2, 3, 4. Alright, so let's label everything here. So this is the right ventricle. This is what's left of the left ventricle, and I'm going to use an arrow here. We have our right atrium, our left atrium, okay, and then we have the arteries coming off of the heart, the great arteries. So we have, and I'm going to, for the sake of just making this a little bit easier to see, we're going to make this kind of a big pulmonary artery here and ignore that heart that's over on top. In fact, let's see if I can, oh no, I can't get rid of that heart. Okay, and then a major problem here is that you have an atretic aorta, at least in the beginning. So it's very small. Okay, crosses over on top. Whoops, this is supposed to be small like a piece of linguine, not thick like I've been drawing it. Okay, and then you have, what is your ductus arteriosus, your DA. So this is the pulmonary artery, and this is the aorta. Okay, but remember this aorta, and I've not drawn it as well as I would have liked. So let me clean some things up here first. Whoops. We're going to get rid of this other heart because it's in the way. And then we're going to make a thinner, more atretic aorta, which is closer to the reality of what we're dealing with here. So, where'd you come from? Let's try this again. get rid of that other heart. I knew it was going to be a problem. Sorry about that. Okay, so we've got rid of that. Now, let's actually shrink this aorta, make it more like it's supposed to look. And sorry about the phones ringing in the background there. I was afraid they were going to light up. So let's just silence them. Alright, so we're going to fix this pulmonary artery here. And this aorta is really skinny up until here where we have the ductus. Okay. And then we have kind of a more normal aorta. And actually we can't see it back here because it passes behind the pulmonary artery. Now, why is this so skinny in here? And actually, let's fix this too, because I have the original takeoff looking bigger than it should. So why so skinny in here? Well, blood passing through the mitral valve into the chamber when you are a fetus is what helps to push open the chamber, like blowing up a balloon. Same thing with the aorta. Blood coming up through the aorta, through the valve, through the aortic valve, into the aorta kind of helps to blow it up. And if you haven't done that, what you have is kind of like one of those long, skinny balloons that you use to make animals. You know, it's skinny, it's not blown up. And unlike those balloons where you put enough pressure on them, they'll pop open, aortas being muscular won't do that. So they're sort of skinny and atretic. Once you get past the level of the ductus arteriosus, however, you can have blood cross the ductus from the pulmonary artery. And so it opens up the distal aorta to be a more normal size. Okay. And so postductally, you're good. All right, so there's several problems when we go to do the surgical repair. The first problem is, remember that your takeoffs to the carotid and subclavian and brachiocephalic trunk are preductal. So you got to get blood going to those body parts. Whoops, what's happened here now? Where'd my heart go? Oh, there we go. Okay. So, and you got to open up the takeoff to the aorta, otherwise you're never going to have a functional heart. So, what was developed is a procedure known as the Norwood. And Norwood was a big deal when it was developed. This is probably the riskiest of all of the complex congenital heart repairs that's done. It's got the most side effects, although the complication rate's gone down over the years, and what we're seeing now is much better than what we were seeing 10 years ago. It's still really involved. This is being done on neonates. This is being done under cardiac arrest and hypothermia. Now, it needs to be done quickly because this ductus is life-saving, and so you have to maintain the open ductus. The way you maintain the open ductus is with prostaglandin. Now, prostaglandin, if you're familiar with it, has tons of side effects. It thins the bones. It causes fevers. It's what modulates shock. So these patients are shock-like the entire time they're on the prostaglandin. Causes high heart rates. The babies don't do real well, so you can't leave someone on prostaglandin indefinitely. It's not good for them. So we got to do the Norwood because we've got to get these kids off the prostaglandin. So what do we do? Well, the first thing we do in the Norwood is we're going to create a neo-aorta. And you can either use Gore-Tex or you can use part of the pulmonary artery. I'm not really sure what is most common these days. And for that, I would defer to some of my attendings from back in the day. This kind of thing sort of changes as technology changes. So they're going to surgically create a normal-sized aorta, what we refer to as the neo-aorta. And we're going to draw it in yellow. To show that it's the augmented aorta here. Okay. Now, at the same time, we're going to create a large VSD. And often an ASD to go with it. This is going to allow blood to mix into what is now a common ventricle. And at the same time, we're either going to band or sever the pulmonary artery here. Okay, we're going to remove the ductus and replace it with a piece of Gore-Tex. This is what's referred to as the Blalock-Taussig or BT shunt. What this does here is gives us a way to mix blood from the aorta and the pulmonary arteries here and again down here. A way to get blood across and up the aorta. We're going to use the right ventricle to do it. So blood flows in from the IVC and the SVC. It's going to come up the aorta. In the aorta, a certain amount of it is going to cross into the pulmonary artery and go get oxygenated. That blood that gets oxygenated comes back into the pulmonary veins, comes back into the aorta, again mixes red and blue blood, and goes back out the aorta. A certain amount of it will recirculate back to the heart, not very efficient, but a certain amount will stay down and go down the aorta and oxygenate the body. By putting this shunt in, you no longer need the prostaglandins, so we can get rid of that unpleasant drug. It also allows us to control the size of the orifice, so we can control the amount of blood going to the lungs. Not too much, not too little. Okay, so that's stage one. When you do this, the kids are chronically hypoxic. They walk around with SATs in the 80s, sometimes even the mid-70s. And that's O2 saturations. If you know what a oxygen saturation monitor is. Okay, these kids are kind of bluish, and they're not all that healthy. We grow them. As they grow, this shunt will no longer be big enough to do what we need, and they outgrow it. So as they outgrow it, the next step is what's known as the Glenn procedure, sometimes referred to as a bidirectional Glenn. And in that, we're going to take the inferior vena cava and usually the right pulmonary artery and hook them together. So instead of going into the atrium, it's going to come up here. So now, blood from the lower part of the body goes straight into the pulmonary artery and to the lungs. Blood from the upper part of the body goes into the right atrium, right ventricle, gets pumped out into the aorta, and goes systemically. Okay? And a lot of times they'll take down this cortex at this point in time. The blood that comes back from the lungs, now oxygenated, will go into the left atrium, pass into the right ventricle, get pumped out through the aorta, and go to the body. All right, we grow the kids for a few more years, and then we go back and complete what is known as the fontan procedure. And in the fontan, we do the same thing, but this time with the superior vena cava. So we take the SVC and essentially hook it up to the other pulmonary artery. Okay, what you have done by doing this is you've completely removed what is the normal right heart circulation. So you have blood coming from body. Let's see, where'd my pen go? And brain goes straight to the lungs. Never goes into the heart at all. Then blood from the lungs, so we do this via the SVC, and now attached directly to the PA, the pulmonary artery, without ever going to the heart. Then from the lungs it comes back to the pulmonary veins. Now we enter the heart. And from the heart it goes into the right ventricle, out the aorta, and to the body. Instead of the more traditional loop that you're supposed to see or that you're used to seeing, which is blood comes from the body to the right atrium, right ventricle, and from the right ventricle to the lungs, making multiple loops this time. This is normal anatomy. From the lungs, it goes back to the heart, but this time it goes to the left ventricle, and from the left ventricle, it goes to the body, making a double loop. So this one's a figure 8, this one is a single circuit. Okay, so you have made here the right heart, or the pulmonary circulation, pumpless. And the left side of the heart, or the systemic circulation, is actually being done by the right ventricle. Whereas over here, the pulmonary circulation is handled by the right ventricle, and the systemic circulation is handled by the left ventricle. What is the implication of that for the patient? Right ventricle, normal right ventricular pressure. I'm running out of screen. Normal RV pressure is 20 to 40 systolic, depending on the age of the patient. Normal left ventricular, roughly. Okay, I'm not a cardiac physiologist, I'm not a cardiologist, I could be off by a few millimeters of mercury, forgive me. It is relatively low. Normal LV pressure depends on the age of the patient. In a newborn, you're looking at about 80 systolic, and in an adult, you're looking at about 100, no more than 140 systolic. And in me, because I'm hypertensive, I've got 3 kids, you're looking, without medicine, at 160 systolic. with medicine we get down. The problem we run into with this fontan procedure for hypoplastic left heart is now you have the right ventricle pumping systemically. You're asking that left ventricle to pump 130, 120 really, to 140 systolic. Well, guess what? It can't do that for 80 years. It tires out. It goes into heart failure. So these patients who've had the fontan for hypoplastic left heart are always 1 foot on heart failure, 1 foot out of heart failure. So they're either in heart failure or they're in impending heart failure. And they don't do, you know, they have a lot of just morbidity for their entire life when you've done this Norwood fontan procedure. You also run into some difficulties because the Norwood itself being done under cardiac arrest, these kids have a lot of learning disability, a certain amount of mental retardation. Though the mental retardation is far from universal, the learning disability is pretty common. So I hope this helps you to understand what it is we're doing, because we're severing arteries, we're removing an entire loop of circulation from the heart, and sewing things back together in rather unique ways, and it can be really complicated. The other problem with the fontan, just to talk about complications, is protein losing and neuropathy. These patients lose protein through their gut. I don't completely understand why it happens. I don't know that anybody does. We just know that it does happen, and when that happens, they become hypoalbuminemic and then develop anasarca. That is a bit of a problem when you're in CHF. So we got to watch the protein levels closely in these patients. So I hope this helps you to understand the anatomy and what it is we're doing in these procedures, these staged procedures for hypoplastic left heart. Eventually I'll go back and talk about hypoplastic right heart, which is pretty similar. We do a fontan procedure, but we don't have to do the Norwood as stage 1. We just place the shunt, and it's much simpler. And with the hypoplastic right heart, the left ventricle pumps systemically, and the right ventricle doesn't do a whole hell of a lot because it's not well developed. But that's okay, because as you see here with the fontan via the Norwood, you can have a pumpless right system. That works. It's when you're asking the right ventricle to pump systemically, you have a problem. In the hypoplastic right heart, you have a hypoplastic right pump, but you know, it doesn't work real well. For all intents and purposes, it's pumpless. But it is there, but it's for all intents and purposes pumpless. And then you have a left pump on the left side, but this time you got the left ventricle doing what it's designed to do, pump systemically. And the patients do a lot better. So it's a much simpler procedure, although the neonates are sicker when they're born for a whole host of reasons we'll talk about when the time comes. So I have in the background a couple of students, and I'm going to start by asking, because this is really a lecture for everybody, you guys included, what questions come from this? Because I've got anatomy going everywhere here now. Are there questions, or does that make sense? Okay. If it makes sense, we're good then. So that being said, this is Dr. Kevin Windisch from Sparks Pediatric and Adolescent Medicine, and this was hypoplastic left heart syndrome. If you would like your child seen by us, please give us a call at 359-7111. We'll see you next time. And I have no idea why there's an ad running.